times more potent than the PPAR alpha phenofibrate that we know. If phenofibrate can lower your triglycerides and you have a molecule which is 1,000,000 times more potent, you're definitely in business. What about its PPAR gamma activation? It is extremely selective, 1,000-fold higher selectivity for alpha as compared to gamma. As we know, the medical world, thanks to America, has had a love-hate relationship with PPAR gamma. Rosiglitazone came, rosiglitazone went, and now we are again wooing rosiglitazone back. Pioglitazone has always been like a veiled woman. You give it, you like it, you want to raise the veil, but you keep her at a distance, but you still look at her. So PPAR gamma, if you have a mild stimulation and 1,000 times more potent stimulation of PPAR alpha, you're definitely in business, because one acts on the high triglycerides and the low HDL, and the other one acts on microvascular disease, because glycemic control comes through PPAR gamma, and the cardiovascular reduction in triglycerides and increase in HDL works on PPAR alpha. So does this molecule do what is the mission impossible? I mean, till now we did not think that we could act on both the PPARs by using one molecule, and we probably do. What is the current state of atherogenic diabetic dyslipidemia? Let's look at lipid management. We have statins, but we all know that residual CVD risk remains in patients, especially the diabetics treated with statins. You bring them to their less than 80 LDL goal, but their triglycerides are still high. So statins alone are not enough in diabetic dyslipidemia. You use fibrates. There are lots of pros to fibrates, but there is an increased risk of gallstones, abnormal liver function tests, and the problem is the serum creatinine. All our diabetics have compromised or will soon develop compromised kidney function. So that's the other problem. So therefore, in these patients, you're not able to use the fibrates along with the statins. So the combination may not always be safe. What about niacin, nicotinic acid tartrate? Again, it came, it was used, and it is discarded. Because it may be potent, but you have to give a large dose. The flushing that it causes is unacceptable. Omega-3 fatty acids are the new kids on the block. Large capsules, foul odor, belching, eructation. Not sure of the results. Extremely expensive. Plus the CV outcomes of omega-3 fatty acids are inconsistent in the different studies. That was for triglycerides. We also have an unmet need always in diabetes, where all the drugs are used and still we have an unmet need. So if you thus have a drug which has a multi-pronged strategy, works on CV, works on diabetes, produces it, then we are probably pleasing the diabetic and shortening your prescription, because you have something which works on PPAR alpha, which is liver muscle vessel wall, and treats the dyslipidemia, and something which touches on PPAR gamma, again fat muscle vessel wall, and treats the diabetes through the alpha as well as the gamma pathway, where the plasma lipid profile and the insulin sensitivity increases. It's a dual action. So you're thinking a little differently, where your prescription is smaller and you're addressing both the issues. I'm going to take you through a study which was published excuse me, in the Indian Heart Journal, March 2015, an observational study to evaluate the safety and efficacy of saroglitazar in the Indian diabetic population. We used a dose of 4 milligrams once a day. The study design was of course multicentric, 4 milligrams in patients with diabetic dyslipidemia, and only patients who qualified on an outpatient basis were taken. Their triglycerides had to be more than 200. Of course, the usual exclusion criteria, and the patients were on ongoing anti-diabetic medication. More than 3,000 patients from 2000 November 13 to July 2014, 9-month study. And look what they found. This is the demographic profile, where we had an average age of about 53 and a duration of diabetes of about 6.5. There was also history of coronary artery disease and an average BMI, averagely high. The patients were in this pie diagram showing were on dual, more likely dual and triple anti-diabetic therapy. Most commonly prescribed monotherapy was metformin, and the patients were on statins or were statin naive. What was the effect of 4 milligrams of saroglitazar? A phenomenal 35% drop in triglycerides and a 23% drop in non-HDL cholesterol. If you looked at the individual parameters, LDL, HDL, VLDL, total cholesterol, across the board within 3 months showed a very good drop. What about HbA1c? As much as a gliptin or even more, to get a 0.9% drop in HbA1c in 3 months' time. And what about the individual parameters, fasting sugar and post-lunch sugar? A significant 25% drop in each of them. Did they do anything to the body weight? Because we are treating with PPAR gamma stimulation. So our bad history of the glitazones does not translate to the glitazars. There was no weight gain. That is because it only touched on the PPAR gamma, did not overstimulate it. There was another study from Science Direct which also showed that the Make in India to Made in India was very successful, also a recent study. But I'm going to take you to a pro-Bengal study, the Sanjay Chatterjee, Mazumdar, Subir Roy group, which did an observational study which was published in the Scientific Reports. It was received in 2014 and later on published, a 14-week study of patients with more than 150 triglycerides who were given saroglitazar once a day. Look at the drop, 56% drop in triglycerides, and again an absolute reduction of 1.13 as far as HbA1c. These are the two pillars, the PPAR alpha and the PPAR gamma. Also the other lipid parameters were in sync with the previous studies, where you had very good reductions in the individual parameters. The fasting as well as the post-lunch also almost a 25% drop, showing that both the studies were congruous and correlatable. The absolute reduction in A1C was about 1, which is very significant to the diabetic. What about its effect on the kidney and the liver function? You see, today you want to look at the side effects. There was not much, in fact, improvement in ALT. Now, why was there improvement in ALT? Probably, if Dr. Vijay Patni calls me next year, I'll have an objective answer to this question, because we are doing a study of the action of saroglitazar on NAFLD. If you remember, pioglitazone and rosiglitazone mobilize fat from the liver by virtue of their PPAR gamma effect. So if I have a PPAR gamma effect in saroglitazar, I will also mobilize the fat and reduce fatty liver. So the ALTs will come down. It does nothing to the body weight. It does nothing to the creatinine. In fact, it is safe in patients with creatinine problems or normal creatinine. So the excretion route is very tempting to the nephrologist. So if you look at the summary, it's safe, it's efficacious. Higher the baseline TG and higher the A1C, higher the reduction. The rule of the land which goes with every drug, and I'm sure Dr. Usman will also tell you about SGLT2, where if you start higher, you get better readings. It's like an obese man at 140 kilos, when he starts dieting, he loses 10 kilos. but the guy at 80 loses only 4. It's a percentage drop. So probably this is the right fit. You have a diabetic. Statins are not addressing his triglycerides. His sugars are there but not exactly. So you have a drug which works on both. It gives you a sense of mastery because you always wanted to use the glitazone, but your hands were tight. Now you have a glitazone without its side effects, a glitazar. And that is what produces the autumn of life and gives the poor diabetic patient a string in its step. And remember, this data we presented, I was there at ADA and at ACE, and I was part of the meeting there, which clearly showed that this is well accepted. And this tells you that with this molecule, we have our finger on the pulse of the nation. I have always believed that the Indian patient is different from the Western patient. And we are never happy these days to accept international speakers who only come here with Western data. Our genes are different, our lifestyle is different, and I always encourage every place where I go to. I'm sure we'll get funds for you, but we would like you to put your records together. Give us data. If India has numbers in the forms of patient, we don't use those numbers to make presentations. My appeal to Dr. Patni and his association today is, keep your numbers together. Let's come up with our observations, because we with our numbers can speak louder than the West with their fewer numbers. And the guidelines which we can frame will be voluminous, acceptable, and more practical as compared to the Western guidelines, who give 80 milligrams of statin, who give 200 milligrams of beta blockers, and who use large doses because of their constitution. Remember, more is not always better. In the West, if you look at the next talk which will come, you have 100 milligrams of canagliflozin available in this country. In America, they use 300. Are they trying to optimize the use of the pharma production? And they call us corrupt. And they look at us and tell us that we are accepting things. So, I want you to make the guidelines, because we will tell the world, like saroglitazar, what to use for us, and Indians are all over the world. Thank you for your kind attention.
Thank you very much, Mr. Thakkar, for his nice, picturesque and lucid presentations. I asking is now it is open to the forum for any question answer. If you have any question, feel to ask.
After the treatment to saroglitazar, the triglyceride level came down to 100, 110. So it should be continued or hold, or the dose should be, there is no.
I think it's a very good question. The question is similar to our statin. The West says keep the patient on 20 to 40 milligrams of statin. What do? We keep that much minimal dose of the statin which keeps his LDL to target. Do the same for saroglitazar. If you find that 4 milligrams is keeping his triglycerides under 100, you can make it 2 and 4 alternative. But if you did that, you'll have to do something for your glycemic control, because your glycemic control might escape a little. But you have to not look at the milligram that the patient requires. You have to look at the target which you need to reach. We are clinicians. We do not take the dictum of the pharma companies. We take what our patients come to us with. Give him a mic, please.
Thank you, sir, for nice presentation. My question is saroglitazar safe in diabetes with special situations like malignancy? Do we have enough data?
On malignancy? See, with malignancy, unless you have compromised organ function, but that too, if you have a bad liver or a bad kidney, you're not worried. So in the special situation, the only special situation that I can think of where I haven't used it is pregnancy. But malignancy, there is no issue because the metabolism would not affect anything else.
Can we use pioglitazar and
No.
saroglitazar together?
If you are using one PPAR gamma agonist, you would not want to use another drug which has a similar action, because you would potentiate and accentuate the action, and you don't want overstimulation of PPAR gamma. So you would use this in a patient who has poor control of diabetes, who despite his A, B and C of OHA or with insulin, needs an insulin sensitizer. You know, today we are using 7.5 of pio or 15 of pio just to open the switch of insulin sensitization. So you could use a weak PPAR gamma like saroglitazar. That's what I said. We don't have trials in pregnancy. So I would be a little reticent because I would believe that 8 or 9 months of hypertriglyceridemia will not kill my patient, but it could do anything to the fetus. The moment she delivers, I could use it.
So I have a question. Why is the metabolically friendly statin like pitavastatin underused in India? Because it serves the population better than most other statins of new onset diabetes, increasing still and reducing the triglyceride, rather than adding a saroglitazar. Why is it underused, pitavastatin?
I fully agree with you. You have asked a question after my heart. The clinical trial for pitavastatin. You know, pitavastatin is a Japanese drug. And I did it for Daiichi Sankyo way back in 1999. Where they introduced it, it's in America available as a drug called Livalo. Here again, Zydus, the makers of Lipaglyn, are making Pitava. And I want to join hands with you and tell them, make Pitava more popular. And I agree with you that amongst the statins, Pitava is the undiscovered treasure and should be used more. But Pitava doesn't do something to the triglycerides because of PPAR alpha inaction like saroglitazar does. Yes.
Sir, there is another new molecule on the block, choline phenofibrate.
Sorry?
Choline phenofibrate. What is the head-to-head with the saroglitazar?
Well, you know, choline phenofibrate is just a polishing of the pre-existing phenofibrate. And they have just come out because of a metabolic cycle change. And they've come up in the last few months or a year or two. There is no head-to-head comparison. But all I know is that the metabolism again is wrought with the kidney problems, which is overcome with saroglitazar. And the PPAR alpha stimulation is more potent with saroglitazar as compared to even choline phenofibrate.
Good morning, sir. Thank you for your research presentation. At the onset, I declare that I don't practice. I am a clinical pharmacologist. But one question always strikes my mind, that when a drug behaves differently in clinical trial and different in clinical practice, like if the clinical trial data shows reduction of 0.3, but clinical practice showing a data of 1.3, we blame or we can find a reason saying that pharmacogenomics for the population will be different. The drug was done a trial in the American and the European population. But with saroglitazar, the trials was done in Indian population. The trial showed a reduction of only 0.3 HbA1c. The same Indian population is treated in clinics now, and the result of A1c reduction is 1.3. That is significantly very different. So what can be a reason for that? The genomics are all same here.
I think very good question. But what happens is, in a controlled clinical trial, the anti-diabetic treatment which the patient is pre-existingly on is not that vigorous as it is, because the action and the entire attention is on the PPAR alpha. Now when you are in clinical practice, you are also interested in continuing and curtailing the sugar increase. So maybe the drug interaction of accentuated oral therapy along with other things is a little more potent, but it's a pleasant surprise. It's like gliptins. Gliptins theoretically lower it between 0.5 and 0.9.
But in the Indian population, we are seeing 1.2, 1.3. So this is a pleasant surprise. I am happy. But as you know, this happens.
So that is the pharmacogenomic difference we can very much agree to it. But here, so should we accept it?